I just got back from Austin, Texas last night, where I spoke to 40 people, orthodontists, pediatric dentists, and not general dentists anymore. We call them primary care dentists. The American Dental Association is even getting interested in helping change the moniker a little bit to people who aren't specialists but are doing all the hard work that specialists can't do or won't do, or will be doing someday, I hope. So anyway, I'm going to start out with a little video that I just came across, and I got about 40 minutes left here, right? So let's see what happens.
Big improvement in airway just with phase 1, right? These things go hand in hand. Malocclusions and airways are all connected. Now, shortly after I finished Anthony, a couple of years in fact, this paper came out, and it basically explained everything that we saw in Anthony. Brilliant paper, hats off to these authors. It's a cone beam study that looks at transverse dimensions at the skeletal level, not the dental level. What this study did, and the authors, the researchers divided groups of patients into 5 separate categories. On the far left side, you had normal controls. Then your unilateral crossbites, bilateral, what we call superior convergent, what JC called that TP, upper teeth reaching out for the lower teeth reaching in. And finally on the inferior convergent, which I see very rarely. They measured skeletal changes and skeletal differences at the maxilla and the mandible at the molar. Now keep in mind, if you're looking clinically, or if you're looking at a set of study models, which I did for the first half of my orthodontic career, this is all I see. A normal control and a superior convergent look pretty similar. When there's no crossbite, oftentimes orthodontists scratch their heads and say, well, I can't expand because there's no crossbite. Where do I go? Here's what they found. When they measured the skeleton, you'll notice that the maxilla is slightly smaller than the mandible by about 1 millimeter in the controls. But look at the superior convergent cases. No crossbites, but their skeletal discrepancy is greater than unilateral crossbites and right underneath bilateral crossbites. So that means these patients have the same skeletal discrepancy, but they're just really well dentally compensated. This was an eye-opener, and their conclusion was awesome. And I tell this to all of the doctors in our community. Patients without crossbites can have significant discrepancies that warrant treatment. Huge take-home message. Crossbites are not the only thing that tells you maxillas are small.
Now, he was talking about an 8-year-old or a 9-year-old, and I've collected about 30 studies in peer-reviewed literature, ortho literature, and they're all on crossbite correction, and they're all mostly kids in the early to middle mixed dentition. Okay, 7, 8, 9 years old. Inclusion criteria to be in that study to qualify as having an indication for transverse development, expansion, RPE, RME, is a posterior crossbite, unilateral or bilateral. Inclusion criteria, you can't be in the study. That's what the protocol is. The IRB, everything. You don't need a crossbite, and who doesn't know that in this room? But you got a high narrow palate. Everyone's talking about high narrow palate, and a V-shaped arch and crowding. Those are all proxies. They're surrogates for transverse deficiency, and we all correct it. We fix it. We do it. Doesn't matter. You don't have a diagnosis, and we're not moving the ball, people. I'm preaching to the choir right now, but this is different. This is a skeletal diagnosis by a board-certified academic orthodontist, Sean Carlson. He knows orthodontic diagnosis. This also justifies taking low radiation radiographs on kids under 6 years old. okay? And that's going to be talked about in July at the ADA course that's been organized. Most people don't know about it yet. It's just gotten to the ADA website. There's a way to skeletally diagnose transverse deficiency without the presence of a dental crossbite. And it doesn't have to be kids that are 6, 7, 8, 9 years old. They can be 3, 4, and 5-year-olds. And it's definitely indicated to take low-dose radiation, the risk-benefit that's there. There's so many things that can be picked up. I mean, when I used to be a conventional pediatric dentist, and I would have to go over consent for a kid who needed general anesthesia for severe early childhood caries, you know what we would say about the risks associated with anesthesia in an ASA 1, you know, a kid who was low risk according to the American Society of Anesthesiologists? Your child will run more risk of being in a car accident, transporting him to the hospital, than he would from the anesthesia. Okay? It's a risk benefit. So I won't get into that, but you do need to take an x-ray to skeletally diagnose transverse deficiency. A crossbite helps. I mean, having high myopia, severe nearsightedness, you know, everyone knows that little 4-year-old needs treatment. Yet we can just look at these kids and watch them get worse and let it get more complex and not do anything about it because you don't have a legitimate diagnosis because there's no crossbite. That's going to stop. And really, we have to start making a difference. And this is something that will do that. Sean Carlson is a powerful force in this whole realm here. So this is what I'm going to talk about today, and something called oral health. And what is oral health? What constitutes oral health? What are components? What are metrics that determine oral health? All right. And, you know, I've done some work in anthropology. I'm an adjunct in anthropology at Arkansas, and I'm working with some Native American skulls that have no malocclusion at Penn. I'm a research consulting scholar with Mariana Evans, and we look at skulls that there's just no malocclusion anywhere. Do you know why there's no malocclusion in the pre-industrial skeletal record of any age, anywhere? There's what? Well, yeah, he's giving me the sign, but actually that's a symptom of it, but that isn't the answer. You see no malocclusion, maybe a little bit of incisor crowding in Egyptian mummies who got mummified, rich people, okay? They still had their wisdom teeth in, but why is there no malocclusion? Even in say, especially in 2, 3, and 4-year-olds, you know, that died, right? Or a 40-year-old. How did somebody get to be 40, right? There's no malocclusion. There's no appreciable skeletal malocclusion traits anywhere in the ancient fossil record, ancient skeletal record. It ain't there till fairly recently. How come? Nobody lived long enough to develop a malocclusion. Why aren't we teaching that? A baby could not survive to live to the age of reproduction, to become an ancestor. You couldn't survive childhood if you had antecedents, myofunctional disorders. OMDs didn't exist. That means you're dead. That means your mom couldn't breastfeed. There wasn't an allo mom in the tribe that was lactating that could breastfeed. You know, they did that, they shared. There wasn't enough baby-led weaning food. There's infection, predation, whatever. There's no appreciable skeletal malocclusion anywhere to be found till about 300 or 400 years ago. And that, how long have we been here? 300,000 years, people. There's no macro evolutionary change. And it takes tens of thousands of generations for that to happen. There's microevolutionary change. We can't metabolize lactose after age 4. You know, that's the wild state. Some of us now have a variation of it, and we can metabolize lactose after 4, but that was never occurred in human history. So that's something I think is really important to know, that a perfect occlusion, meaning, you know, that you had enough room for your tongue early in life, or you didn't go anywhere. I'm trying to get to the. Okay, so what are the metrics that determine oral health? This came out this year, early this year, from the American Academy of Pediatrics. And all over it, oral health, sugar, caries, fluoride, brushing, flossing, dental caries, fluoride. I counted it up, but I lost count. It's 5 pages. Look at that. Oral health, brush, fluoride, caries, tooth decay, brush, decay, tooth decay, fluoride. Look at that. Fluoridated toothpaste, brush, toothpaste. 5 pages. Look at this. It's ridiculous. Fluoride varnish, fluoride, tooth decay, caries. That's oral health. Why is it? What's missing? Malfunctional disorders, malocclusion. How about it? TOTS, tethered oral tissues. Nothing there. Steve hears me bitch about this all the time. And sometimes we write letters like the AAP, look, please, there's more to oral health than this. Just ask the American, Steve Carstensen started a whole task force at the American Dental Association on oral health as being a component, as airway health as being a component of oral health. Plaque-mediated dietoinfectious dental diseases. That's oral health. That's synonymous with oral health. That's just what makes the media. Whose fault is it? It's not their fault. Where are they supposed to get this knowledge? From us. We have an identity problem. We drill, fill, and bill. We put out surefires our whole career. Who wants tooth decay to go away in dentistry? What in Chicago, say people are making their living filling potholes. Do they want an asphalt to be created that is resistant to making potholes? No, they're going to be out of a job. I mean, it's like a clergyman becoming an atheist. What are they going to preach about on Sunday, right? Dentistry is so locked into this plaque-mediated disease. And it ain't going to change until we start to show we can make a difference in kids' lives. Okay, like Mark said, the most amount of kids getting the best airway at the earliest possible age. That's what we're trying to do. Okay, so these are diseases. What, malocclusion? Is malocclusion a disease? It's a developmental disorder. That's what they say. It's a developmental situation. It's not a disease. Bullshit. Okay? It's a disease. Sorry. Get the censors out there. But malocclusion is a disease. It's absolutely a disease. Okay? And you don't want to believe me. The ADA, look at this little, and this is something on our task force that we developed, a screening form that is we're in the process of trying to raise money to get it validated scientifically. But this is something Steve Carstensen initiated. It took about 3 years to develop it. Did a great job. It's out there now. We hand it to everybody. You can't read that. Sorry about all that writing there, but look at that, front and center. And I highlight this and I give it to every parent that comes in. Mouth breathing is a component of oral health. Look at this, disordered breathing, tongue positioning. Look at that, oral health. Oh my gosh, jaw and airway development. Started before health problems. We could do the shape of the mouth and the face. What, that myofunctional? What's going on there? The face? What's the face got to do with oral health? The face? How about this from 100 years ago? 1921, Dr. Johnson was chairman of orthodontics at Harvard, right? The face has evolved with the functions of mastication and respiration. That's over 100 years old. The face, distal occlusion. Do you know what distal occlusion is? A distal step molar. When does that happen, right? Starting at age 3. And guess what? Dr. Bishara, who was my growth and development and cephalometrics instructor at Iowa back in the 80s, wants a distal step, a class 2, always. It's a proxy for a skeletal retruded mandible. Also a maxilla, we found out later. Dr. Bishara didn't talk about that. But distal occlusion, primary occlusion, and if you have a sagittal discrepancy, if your upper and or lower jaw are too far back, if you have a vertical discrepancy, you're growing adenoid face, long face syndrome, or you're short, you've got a deep skeletal overbite, and you can have a deep dental overbite and a skeletal open bite. How are you going to find that? Unless you're from Krypton, you got to take an x-ray on a 3, 4, and 5-year-old, okay? And I am going to defend that in July with evidence talking about microsieverts and radiation that you get by just walking outside. A Panorex is about 2 days of background radiation, and it's safe and the kids are shielded. I won't go into that now, but it's important because you'll say, well, you can't take x-rays, you can't really make these skeletal diagnoses. Oh yeah, you can. And the other things are proxies. The V-shaped palate, the nose space between the teeth, the high narrow palate. Those are all proxies for what you might see on an x-ray. Not necessarily. You got to take the x-ray to know. Again, I won't go into this very much, but people have heard me talk before. I really am a nerd for old medical and dental literature. I read this stuff. Look at these titles. The Relief of Nasal Obstruction by Orthodontia, a plea for early recognition and correction of faulty maxillary development. Maxillary development? Why? You got 2 jaws. Ben Moralia taught me this. The maxilla is the criminal, the mandible is the victim. Almost all skeletal malocclusion phenotypes in any of the dimensions, sagittal, vertical, they always involve a transverse problem first. Almost always, ubiquitously. If you're going to do nothing else, you don't have to want to treat these 3 and 4 and 5-year-olds, and you just might not be comfortable doing it, then don't do it. You shouldn't do it. But if you understand the impact you can have on these children's QOL, maybe that's all you wanted to, hey, that's a biggie. But what are the things that make quality of life bad or good? How about good sleep? How about impulse control? Things like that can happen just by optimizing the transverse dimension. The first thing you got to do is recognize there's something wrong with it, and it's non-self-correcting. Transverse deficiency will never, ever self-correct. A dental crossbite can self-correct, okay? Not skeletal. And a sagittal skeletal deficiency will not self-correct. You know, a distal occlusion, a mesocclusion, that's what they used to call class 3 in little kids. And vertical, take your hat off to vertical. If you see excess vertical, adenoid face, long face syndrome, you must make those parents aware. It will always get more vertical. Always. It never stays the same. Unless you eliminate the source and then start to do things to run it in the opposite direction. So you don't have to make a kid perfect by 5. Oh, all dimensions are perfect. But the least complex to optimize age appropriately is the transverse dimension. And I'll give you a little metric. We call it the Bolton Canine Index from the Bolton Brush Study, longitudinal database from Case Western from 1930 to 1950. Paul Newman was in that cohort. See how he turned out? And there's others. The Bogue Index. Augustus Bogue was a physician dentist in the late 19th, early 20th century. Thousands upon thousands of children he treated in Paris, London, New York, Boston at the Forsyth Dental Infirmary, and Chicago. And he had study models, and there's lots of literature that what he did, he would measure at the eaves, at the upper second primary molars, at the gingival margin, and it was 24 plus their age. That's what he used. It was an index. It's not diagnostic, like body mass index does not diagnose overweight or underweight. It points to, it's a secular trend of adiposity. I did my first healthcare degree in nutrition and dietetics. I got a master's degree in nutrition and dietetics, and I learned all that stuff about an index versus a diagnostic. The Bogue Index is very reliable. It correlates with other validated metrics.
What if we could take a baby and watch everything that happened to them from birth to grave? If we could examine every aspect of their life, look at everything that made them who they are, their genes, their physical well-being, their personality, their emotional ups and downs, criminal convictions, relationships, illnesses, successes, failures, the lot. Then imagine if we could do that for an entire city. Perhaps we could see or uncover what it is that really makes us all who we are. That experiment has already begun.
It's probably the world's most successful longitudinal study of a general community sample ever.
The Dunedin study is known in our field, in many fields, as a hallmark and landmark study.
In 1972, a medical school from a small New Zealand city decided to take every one of the 1,037 children born that year and follow them for life. Those children have become the 1,000 most studied people in the world. For almost 4 decades, every aspect of their lives has been monitored in detail. The experiment is called the Dunedin study, and it is now the broadest and most in-depth study of human beings in the world.
It goes a little longer. It's very interesting. Google it. This is amazing. And I've only recently found out about it. QOL, quality of life, quantity of life. Okay? What we are doing when we are optimizing a child's ability to move air through the nose during wakefulness and sleep at the earliest possible age, and you can say this with a reasonable degree of scientific certainty now because of the Dunedin study. It's 1,037 babies. Over 1,000 of them are in their 50s now, or late 40s, early 50s, whatever, 1973, yeah. So anyway, late 40s, early 50s. And they're still being followed on the Dunedin study. Guess what they found out, okay? Kids by age 11, this is the take home for everybody here. By age 11, any kid who demonstrated with validated metrics that they had good impulse control and they did sleep, they did all kinds of testing on these kids. You know the marshmallow test? This was before the marshmallow test, but they did things like that to see which of these kids had self-control. They didn't correlate good sleep with this, but they measured sleep. And so I'm digging into all this data. It's available to anybody. And these kids, when they are in their mid-30s to early 40s, they had almost no cardiovascular disease, almost no diabetes, almost no obesity. They managed wealth better. They had less criminal and addictive behaviors. And through facial analysis on morphing studies, their faces look 10 years younger. The kids who had self-control before the age of 11. So I'm saying is that all the things that we are trying to do, we're releasing the TOTS, we're trying to eliminate first diagnose and eliminate the myofunctional disorders, try to optimize their craniofacial respiratory complex morphology, improve their function. Has anyone heard, oh, they're doing better in school? Oh my God, the dark circles are going under the eyes. He's so much easier, she's so much easier. Anyone watch Finding Connor Deegan? It's not scientific, but you know what? That is sort of indicative of what it is that we can give parents. I don't say this is going to happen to your kid. This is absolutely going to work. And like you said, we don't recommend CPAP. We don't even we get them to people who can confirm a diagnosis of adenotonsillar hypertrophy. I don't recommend a kid get their tonsils out. That's not up to me. I'm a dentist. I diagnose malocclusion and I fix it. I get them to the myofunctional therapist. I get them to Steve Sheldon to get a sleep study. I get them to the ENT to be evaluated of what I'm thinking. But working together, we are improving these children's ability to have better impulse control. Quality of life. There's lots of literature. This is something that they call health span, lifespan and health span. These kids are going to live longer. You can tell parents about the Dunedin study. Let them make their own conclusions. What I'm doing is going to help your kids sleep and breathe better. That likely can not only help them live longer, but stay healthier longer into their older age. It's called health span. Start using it, please. You know, right now our lifespan 77, 78. And when do we start getting heart disease and diabetes? Late 30s, mid 40s. That's a crappy health span, right? This is something we are doing for these children. Besides optimizing their myofunction, they're optimizing their occlusion, their airway, their sleep, quality of life. How come? What else? We're going to help them live longer, and we're going to help them stay healthier into their extended lifespan. So I was glad to hear Takashi talk about prenatal factors, something I've been interested in a long time. How about assessing risk for tongue tie? tongue tie. It starts in utero. These things, they don't go away. They don't suddenly appear. They're there at birth. They're there before birth, right? Malocclusion. They're starting these kids. They need a crossbite. Okay, and they're 8 and 9 years old. What did they look like before? What Sean Carlson was talking about there was an 8-year-old that he was treating. Well, if it works in an 8-year-old, it'll work in a 4-year-old. And it was there when they were 4. Okay, Audrey Yoon's study, her last one and her new one. You know, the one that showed that the adenoid lymph tissue normalized with transverse expansion alone. Well, that's because of nasal widening, right? And decreasing nasal resistance. Yeah, that too. But it increased the depth of the bony nasopharynx. The distance from the posterior nasal spine to basion, the front of foramen magnum, it gets bigger. And the adenoids normalized. And what they didn't notice, Bacow and Audrey in that paper, the premaxilla came forward. It's right there. I drew it out and showed. And this is the Linder-Aronson metric that they show when you expand, you open up that bony nasopharynx, even kids with large adenoids, they start to breathe better. Not all of them need adenoidectomies. So oral dysfunction, orofacial myofunctional disorders, OMDs, these are things that, oh my gosh, the Academy of Pediatric Dentistry, Kirk, they didn't teach us how to evaluate this stuff. Dental age 1, you know, infant oral, we didn't learn how to do any of this. Swallowing and feeding problems, what Katrina was talking about. Oh my God, these kids are aspirating food. And I saw them at age 1. Oh, you know, here, let me tell you when you can expect to start, you know, needing to take x-rays and all the things we do, they're normal, but we're missing all this. And how come? You can't blame the pediatric dentist for that. It's you malfunctional people that you have to make a lobby and you have to petition the pediatric dentist, the Academy of Pediatric Dentistry. Look, you guys need to know this. We can't get mad at orthodontists. Their curriculum doesn't even have behavior guidance for little kids. Kirk and I and other pediatric dentists, we got no problem. What if a kid won't open his mouth? We don't give a damn. He'll open his mouth for us. We got ways. And it's, you know, what I do, I say, Billy, guess what? You don't have to do anything you don't want to do here. This is a friendly place. So here's a big old bike horn. So if you change your mind, I'm going to go up and take a nap. And you can wake me up, and I'll come back down. Oh, man. But if you don't want to, Mommy can just take another day off of work, okay? And then I just leave them with Mom. And, you know, it works like, get yourself an old bike horn. It works so good. And then I have my staff come around. Look how big he opens. You know, old pedo trick, right? I mean, we know how to do that. Orthodontists, huh? Well, I don't know what to do if they, and what the heck? I mean, we can fix it when they're older, right? It's not their fault. It's their curriculum. So don't get mad at them. Get mad at their curriculum. We got to change it. So that's been it helps lower my blood pressure because I do get mad at them. Okay, so there, you know, the face. There's Linda D'Onofrio. She's talking about the face again. What's the face got to do with oral health, right? Here we go. And I was so glad that I think, was it Takeshi, he was talking about adenoid, adenoid hypertrophy. Well, this metric that Linder-Aronson established for the posterior, the bony nasopharynx is incredible. You can send this to your ENTs. You get this on your cone beam and you can measure that. If it's not a certain number, that kid's at risk for a life of mouth breathing. It was validated in the 70s, thousands of kids in Sweden. Look at this. And I went back and redid all my x-rays after I read Audrey's paper and saw that whole area opens up, that even sometimes the adenoids wouldn't normalize, but that whole maxilla came forward. Soft palate got shorter, right? I've got this in so many kids where I can show that this changed. So let's do a little quality of life. And I'm going to go real fast now because I don't know, is Milt going to go right after me or are we going to take a break? No, we're going to keep going. Okay, quality of life. Look at all those papers. That's just a few. I got 20 of them that talk about transverse expansion, rapid expansion, and quality of life. If somebody benefits from rapid expansion, what must have they had pre-treatment? Transverse deficiency. Oh, but they all had crossbites. Well, you don't need a crossbite, and you don't need to be that old. You can be 3, 4, and 5. Well, they're going to need more treatment later. Well, so does a kid who needs glasses. You know, you're still going to give them glasses, right? So anyway, lots of this. Okay, this is a self-control. It's in there. Tell your patients or hand them the article. Dunedin study, self-control, quality and quantity of life. It's incredible. Okay, so I'm almost done. I just got to finish my rant here. So RPE, it's just, you know what? Even if this is all you're going to do is recognize it and get them to somebody who will do it. Okay, and I think when more orthodontists understand the benefits that will happen from this, they're probably going to get good at doing some behavior guides. You know why? Because it increases market share. They're going to lose market share, and nobody wants to lose market share. Okay, so I think the orthodontists will come along. I really do, but we got to start doing it. And you know, here's the study here. You know where it you know, the adenoid shrunk, of course, but look at the anterior. It's come forward. And that wasn't even mentioned in the paper. So these are kids that you know, right away, there's sagittal problems. I'm not going to use them all. Yeah, he told me I'm only halfway through my slides, but I don't have to show them all. I just want to show you, early childhood, where do we come up with that? These kids obviously have sagittal problems. What does that girl over here have? Yeah, sagittal. You know what else? Needed an x-ray to find out what was her problem, all right? And I never would have known it otherwise. She had a dental deep bite, the one on the end. This one obviously was a class 3. I expanded, protracted, and there she is. She was told she needed surgery. I started her at 5, right? Here's another one. Its mandible was back. That's obviously a sagittal problem. They both also had transverse problems. All right, it's not going, Mark. What do you do? Okay, sorry. Okay, so I use this, red light, vertical problems. They're the most complex to fix. You got to get control of them, acknowledge them, but you don't have to make them perfect when they're 3 or 4 or 5. You have to arrest it. Sagittal problems, you have to prevent them from getting worse, and you guide them forward. But idealize the transverse. You can do it at 2, 3, 4, and 5 years old, age appropriate. You can optimize it. Okay, so this is what the one little girl had. She had, look at that. She had a dental deep bite, and look at that skeletal. Okay, she had a gonial angle of almost 40. Anything under 30, you want it to be under 30. Okay, she had adenoids. She was a mouth breather. So, you know, but the main thing is, why do we get early childhood caries? Means tooth decay before 72 months old, under 6. I say there should be a whole system like that of diagnosing malocclusion, but there isn't yet. Early childhood malocclusion is any skeletal malocclusion phenotype before 72 months old. I want to get this into the ICD-10, International Classification of Disease. It's not there yet. And it's severe if it's comorbid. Don't say a risk factor, even though it might be. You don't have to satisfy those criteria. They are comorbidities. Malocclusion, sleep disorder, breathing, OSA, comorbidity, the behavior traits. Okay? And when you resolve one, you often resolve the other. Steve Sheldon used to say, and you would close the door and say it real low, ADD does not exist. Okay? As defined, you know, by the diagnostic DSM, whatever it is. But when we would resolve sleep apnea, oh my God, most of the symptoms that overlapped went away for ADD. Go figure. Well, this is the same thing. You know, there's so many things that we can do to optimize kids. And, you know, so this is it. You know, craniofacial respiratory complex, we have it in all kinds of publications now. These are obstacles to treating. Dr. McNamara acknowledged, yes, you know, we could treat in the early dentition, but we don't do it because, oh my gosh, a 3 or 4-year-old, they're not capable of understanding, right? They're not capable of understanding. Well, they're not capable of understanding why they don't need to cross the street when the light's against them either. But their parents hold their hand, right? If the parents understand that this is in my child's best long-term health interest, short-term health interest, quality of life, oh, that kid will, what do they want to do? They want to please parents. Kids are hardwired to want to assimilate adult culture. All right? It's just that is really something, this is the last point I want to make. Kids are hardwired to imitate. It's in our genes. We wouldn't be here. We'd be extinct right now if babies did not want to imitate their parents. And please, if the parents understand, then you are home free. You can get these kids to comply. I use removable expanders in a lot of these little kids. You know what? And it's fine. That's a Cro-Magnon, you know, look at that. They learn how to make spears.
All right.
And this is, I got a parent engaged here, right? The mom's showing her kid, look what's happening to you. Look at the C-spot, and look at your airway. You know, you think that kid wouldn't do anything for that mother right now? And I started him at 3. Right? Look at that airway. Okay, so I'm done. That's all I got. So, okay. Bingo. Yeah, thanks.